My name is Evan Evans. I'm a sergeant with the Department of Public Safety for the University of San Francisco. Growing up, I was always athletic. I got into tennis big time. I got a scholarship to a major university, which, due to a knee injury, ended. I tore the lateral meniscus in my right knee. And instead of stapling it down as they do now, he removed the whole thing. So I've been without a meniscus since I was 17 years old. I was on the women's crew team for a few years. After that, became a professional cyclist. Over the years, I gradually had to winnow down the activities I did because of the knee pain. I kept my ear to the ground in the orthopedic medical community. I waited about 5 years after I'd heard about this because I wanted to see how it worked. I found the right doctor, and I have nothing but good things to say about the results of that surgery. I had to readjust my whole boat to my new flexibility and readjust my stroke, to be quite honest. My knee is now custom. My knee is in perfect alignment. The beauty of this particular technology is that it removes what needs to be removed and nothing else. I would recommend this in a heartbeat. Being pain-free, where I had spent the last 37 years in a significant amount of pain, I didn't know what that would feel like. There was that day where I got off the water, and it's like I walked into a quiet room. There was no pain, none. And I was so used to crawling out of my boat that I actually got out of my boat, stood up, and was like, that's weird. That to me has been the biggest gift, to not be in that level of pain.
At this time, I'm privileged to introduce Dr. Harwood. Dr. Harwood is from University Orthopaedic Associates. He's been a member of our medical staff for many years. We certainly appreciate him for his efforts and being part of the St. Peter's team. Dr. Harwood obtained his medical degree from UMDNJ, Rutgers Medical School, after earning his undergraduate degree from Princeton University. He completed his internship at UCSF in San Francisco and his residency at UMDNJ, Robert Wood Johnson Medical School. You can see it there. Following his residency, he completed a fellowship specializing in joint replacement and arthritic surgery at the Cleveland Clinic. Dr. Harwood is a clinical associate professor of orthopedic surgery at Rutgers University, Robert Wood Johnson Medical School. And through his career, he's been recognized for his accomplishments and his skill, including elected by his peers for inclusion in Best Doctors in America. On behalf of all of us at St. Peter's, I'm proud to introduce Dr. Harwood.
Ready? Thanks for coming. Can you hear me? Yeah, so I've been around a while. I grew up just down the road a ways. I went to medical school here. Is this okay? Closer? That's good? Bad? Bad? Worse? Good? Okay. I went to medical school here. In fact, my very first clinical rotation was at St. Peter's Hospital. That was like, I think it was 1876, but yeah, it's been a long good ride. I went to residency here as well. I spent most of my residency in St. Peter's Medicals, in the emergency room. So it was nice to come back to the community and practice in basically in New Brunswick. We're doing a lot of exciting things in the knee replacement world. So I'm glad we have the opportunity to talk about one of those really exciting things. So the main diagnosis that we're going to be talking about tonight is arthritis. And you know, this is a lesson in reading films. Can you guys see those x-rays, or that's too bright? So this is the reason I went into this business. It's basically, you get to look at pictures and shapes and things. You don't have to read a lot. It's awesome. So you can see that the first thing we do to diagnose arthritis is x-rays, because it's, number one, the quickest and easiest, and it's also usually the most specific for arthritis. You don't usually need fancy tests. X-rays kind of tell the whole story. So you look at the x-ray on the left, and you can see the space between the bones. Well, that space is the cushion. It's cartilage. It's what God gave you. It doesn't show up in the x-ray, so it looks like there's a space. Now look at the x-ray in the middle. Did anybody see anything different about that? So it's pretty obvious, right? Again, that's why I went into this business. Okay, it's very, very easy to see. The bone on the one side of the knee, the bones are touching, right? So even though you can't see the cartilage, if the bones are touching, you know that there must be no cartilage there. And then you look on the knee on the right, if you can see it, and there's basically almost no space for the whole knee. So you can see that there's different levels of arthritis as well. So the one on the middle isn't as bad as the one on the right. And we all want the one on the left, but sometimes God has other intentions. Now, this talk isn't really to convince you all to have surgery. I mean, the surgery is what we're going to talk about, but just to be clear, this is only if you really need it. And certainly there's other things to try first. And we always encourage people to lose weight. It's kind of hard, and a lot of folks have been struggling with it their whole life. So, those things are limited, but they can work. Lifestyle modifications, it gets to the point, though, when the lifestyle that you're giving up is something that really is important to you, then that doesn't work so well either. Anti-inflammatory agents, sometimes people can take those, sometimes they can't. They can help if you can. We can try some injections, which I do all the time in the office, cortisone. There's the gel shots, or they call it hyaluronic injections, but we call it gel shots, just to make it easy. Braces can sometimes feel a little bit better. I'm not a big brace person, but that can help. TENS, again, it's something the physical therapists use. It's just for pain relief. That can help a little bit. Stem cells I would probably avoid. You hear a lot about stem cells in the news lately, right? Everyone's talking about stem cell this and stem cell that. Well, they do work in certain areas. Unfortunately, arthritis isn't really one of them, and it's never been proven to help. So if it's not been proven to help, insurance companies and Medicare realize that it's expensive, so they're not going to pay for it. So I've had people come to my office and spend tens of thousands of dollars on shots that we know from the beginning would never have worked. So all these things are fine. I'd stay away from the stem cells, though. So just like those x-rays I just showed you, all arthritis knees are not the same. So all knee replacements are not the same. So my philosophy, and a lot of doctors' philosophies, but not everyone, is that why would we replace what's good in your knee? There's all these different parts of your knee. And if only one or two of them are worn out, why would we replace the other ones that are pretty good? So this is the philosophy of my practice, where is if you have just one part that's arthritic or worn out, you just replace the parts that are worn out. Turns out that the rest of the knee usually doesn't go and get arthritis. You correct the arthritis, correct the alignment, it actually cures the arthritis and prevents the rest of the knee from falling apart. So not only does it usually not continue, it actually prevents it from continuing. So that's pretty cool. So what we're going to talk about today is this particular device. We call it a robot, but it's a little misleading, and I would love to have a robot do my surgery for me. Then I could just set it up, and then I could go in the surgeon's lounge and drink coffee and answer my emails, and then come back when the surgery was done. But no, I actually have to hold. It's a smart device. I actually have to hold it in my hands, and we'll talk about why it's so smart. But it is in my hands the whole time, so you can be assured it isn't something out of Star Wars or Lost in Space in the old days. So first, I'd like to thank these two people, and you probably don't know who they are, but the gentleman on the left is Leslie Hirsch. He's the president of the hospital, and the gentleman on the right is Dr. Tria, who is an orthopedic surgeon and the head of orthopedic surgery at St. Peter's. He actually taught me, again, in probably the 1800s, how to do knee replacements in the day, and we're good friends. But both of these gentlemen, along with me in consultation, agreed that this technology should be brought into St. Peter's Hospital. So it's in unison with these folks that they had the insight and the foresight to invest in some of this technology, because it's not cheap as an initial investment. So basically, the reason that I like to do partial knee replacements in the right candidates is that they really do well. The knee replacements in general, they do pretty well, but not 100%. And when we look at the satisfaction results between the two, the partial knee replacements, if you're a candidate, they actually are happier in the long run, and it's quicker, easier operation to go through. So it's really dependent on your x-rays and your symptoms, and not everybody's a candidate. But in this, in this country, we've kind of been behind Europe in doing these partial knee replacements. Only over the course of the country, about 8% of the total knee replacement candidates get partial knee replacements, when in reality, 30 to 40% are really candidates. So it kind of depends on who you go to. It's a little scary, but it's true. People have different philosophies. Different surgeons have different philosophies. But in reality, a good percentage of people could have a partial knee replacement compared to a total knee replacement, and giving you all the advantages of what we just talked about. In fact, I did all the numbers a few months ago, and in reality, 30% of my knee replacement practice are partial knee replacements. So if you come to me and you have surgery, you have about a third of chance of actually getting the partial instead, which is kind of cool. So partial knee replacements are great, but again, it kind of depends on how they're done. And you can see that if you don't do them properly, you can have problems. Now, not to go into the details, but you can see from these different x-rays that sometimes things, they just kind of look cattywampus. Like this, it kind of looks crooked, right? That's probably not the way it's supposed to look. Well, you're right, it's probably not. Or the one on the far right is probably not, it's not supposed to be crooked like that. So not to go into the details of why it's bad, but it's bad, and it could lead to failures early on. So not only is the choice of surgery important, but how it's put in is critically important. If you are not a candidate for a partial, but a total knee, all is not lost. The field of total knee replacements has been advanced incredibly in the last 10 years. So we're really at a good time, if you ever needed a surgery, that it is extremely successful and durable, and we'll talk about some of those details. So knee replacements of all types are great, but it's been shown that 50% of the ones that need to be redone in the first 2 years are because of some issues in placement of the implants. And the reasons would be, loosening, instability, or malalignment. All those things are directly related to how they're put in the first place. So although it's not a high percentage of failures, the ones that fail are highly related to how it's put in. So it would be nice to have a tool to make sure that you're not one of these statistics, right? You don't want to have it redone in the first 2 years if you don't have to. So the traditional instrumentation is kind of what you see here. We have rods, and we have cutting blocks and things that clamp on and things that compare. And these work really well. In fact, they were a huge improvement over what we used to use, was basically, your eyeball and, whatever you thought looked good. So they're a huge improvement, but they're still related on technique. So I've done over 8,000 of these things, so I'm pretty good with the traditional instruments, but it's still like, put it this way, Einstein probably used a slide rule, right? I mean, they didn't have calculators now, since Einstein was a genius. So you can do it with the old equipment, but when new technology comes around, why would you use the old one when something new is better? So this is what we're talking about.
The NAVIO surgical system has a small footprint that seamlessly integrates into OR workflows. Instead of a preoperative CT scan, mapping of the bone surface is done intraoperatively and is used to create a 3D representation of the bone structure. Advanced planning software allows the surgeon to virtually position the implant and balance soft tissues throughout the full range of motion prior to bone resurfacing. Robotic assistance is delivered through a handheld tool. Computer navigation tracks the position of the robotics-assisted handpiece relative to the bone surface. The surgeon accurately removes the damaged bone surface using robotics assistance, making room for the implant. The final step confirms the implant is placed accurately, as intended, based on the surgical plan.
Isn't that cool? So do we need that? I mean, like I said, most of the knee replacements that I've done prior to last year, they do really well. But think about it. If you buy a set of tires, right, for your car, the guy's not just going to put your tires on. It goes through this, ridiculously fancy balancing technique, dynamic balancing, so your tires last longer. So does it make any sense to put your knee replacement in with technology that's not even as good as the guy that puts your tires on your car? So that's kind of the way I look at it. And when you do it that way, these are the kind of x-rays that you get. Now again, the details of it you may not completely understand, but you kind of can see it's pretty straight, right? And that's kind of what we want it to look like every single time. And with this new technology, we can. And although it doesn't guarantee a perfect result for every reason, at least you know that the knee implant is not going to loosen early or wear out because it wasn't put in properly. So this, I didn't know we had this video, so we'll watch it for a little while. So this is the NAVIO for a total knee replacement as opposed to the partial. And this is what we do in the beginning. We basically paint, and the computer knows and can see the pointer, the surfaces of the bone. So now it has a model of what your bone actually looks like. And then we do planning with both the implant placement as well as moving your knee and stressing it in different directions so it knows where the implant should be. And then we can modify everything perfectly so that your knee is perfectly balanced. And then it's the same sort of thing with the robot placing the cutting jigs in the right spot. The right spot meaning exactly the spot of the plan. So the technique is slightly different, but the result is the same, and the concepts are the same. So all those little cuts are kind of shaving the end of the bone to make that implant fit perfectly. And that's on the femur side, and this is on the shin bone or the tibial side. And that's where the cushion is, or the plastic. So there's another concept of this talk that I'd like to bring out, in that more has happened in knee replacements over the years than just the robot. I mean, the robot is awesome, but I've been around a while, so I've literally done thousands and thousands of knee replacements, and it's changed so much. The experience has changed so much for the patients over the last 3 decades. In the long run, in my experience, patients have always been pretty happy with their knee replacements, but it might take 6 months. And getting through the initial process or procedure was really, really painful. And so when I looked at my patients, I felt bad. Hip replacements always seem to do better in the beginning. I used to go into my waiting room, and a month follow-up, I'd look at the faces of my patients, and I could tell which ones were hips and which ones were knees, whether they were frowning or smiling. But lately, I really can't tell them apart because we've had some other advances that are really, really beneficial for patients. So when I looked at these patients, I made it my goal to try to make the whole experience better for the patients, not just the outcome. So the main things that we did, and not to bore you with this, but we have nerve blocks. I have my anesthesia friends put a nerve block in every patient for postoperative pain management. What that does is it numbs the nerve that brings pain to your brain without doing anything to the other nerves or without having the side effects of a lot of narcotics, which you heard in the news now is really bad in the long run, right? The opioid epidemic. So we're trying to minimize that. The more opioids you take, the dopier you feel. You get constipated, you get sick to your stomach. So you'll still need some of that, but it's much, much less because of these new techniques. And then our surgical techniques have improved over the years, so nobody ever needs a transfusion. We also get you walking within, if it's at the end of the day, it might be the next morning, but otherwise you get up and walk the same day of the surgery. Pretty crazy. When I was training as a resident, patients would stay in bed for 5 days with a bandage on it. So it's so different now, and it's so much better. So this is my anesthesia colleague in here in St. Peter's putting the nerve block in. And they basically just run some Novocaine, just like a dentist would use on your teeth. And they find the nerve with this ultrasound device. And they're very sophisticated at finding it and putting the tiny little catheter, like an IV, right next to the nerve. And then they just drip this Novocaine automatically for about 3 days. So it's not just for the surgery, not really for the surgery, it's for the postoperative pain management, which has really been revolutionary. So this is literally what my experience has been. For the first time ever, after instituting these things, a good percentage of my patients want to go home the next day. Some people stay 2 days, and some people even stay longer. But when I was a resident, everybody stayed 2 weeks. So it's really, the change has been dramatic, but this final bump up in the pain management with the nerve blocks has been the final, I think the final push, where they really can go home the next day. So basically, what we talked about this, the benefits are you'll get your knee put in perfectly accurately, and it's individualized for every patient, and we do it in the operating room. It only takes about 5 minutes to do the planning in the operating room, and since we do it in the operating room, we don't need a CT scan. So there's another robot system. You have to get a CT scan ahead of time, which is expensive, and it also has radiation, so you don't need extra radiation. Whereas this particular system, we map it and plan it in the operating room. It takes about 5 minutes, and it's really pretty easy and pretty quick and safe. And this device now, initially was just for partial knee replacements. Now we can do partial and total knee replacements. So if I want to see. So this is the machine over here. We're going to put it up on the screen. It takes a while to switch over. But this is the kind of thing that I'm actually looking at in the operating room. And I can either manage the screen or I can tell my assistant what to do. But you can see this is a femur, this is an implant, so the sort of goldy greenish part is the part of the bone that I painted, so it knows where it is. And then the sort of silvery part is the implant. And you can see how we can change the position. This is before any surgery. This is just making the plan. So we can put that implant exactly in the position that we want. And then we can also take it through a range of motion virtually and see where that implant is going to rub on the other implant and make it absolutely perfect, the whole range of motion. So this literally takes less than 5 minutes, but when we finally say, okay, that's what we want, you can see, you can move the implant, you can see how the top left and the bottom left, those are dots where those two implants come together. So that looks pretty good in the middle there, but if you move the implant over one way or another, you can see that it gets to the point where it's bad. And that's what can happen if you don't have a particular technology like this, where it's not in the perfect position. So, good. That's good news. It's a while to switch over. And we're just about done, so we can go back. Oh, I pushed. same one again. So I think, Jack, do you want to say something about the cards?
In your packets, first of all, my name is Jack Martins. I'm out of Minneapolis, and I help put these programs together. And one of the things we do is we try to keep track of how you heard about the event and kind of what brought you here. So if you notice in your packets, there's a little card. We'd like all of you to fill those out if you could. It's a nice way for us to understand how you heard about it and what marketing mediums we want to use again in the future to reach out to people like yourself that have challenges with their knee. So if you wouldn't mind filling that out before you leave today, and then I don't know, you can give it to Michelle or myself or Daisy. There's a number of us. You can just give them to us on your way out if you would. Thank you.
So before we open it up to questions, which we will, so you can relax. I'm not leaving until your questions are answered. So graciously and coincidentally, one of my lovely patients came in today while I was in the office, and it was one of the patients that we had done a partial knee replacement using the NAVIO system here at St. Peter's. And so I'd like to turn the microphone over to Mrs. FedEx, Marion FedEx, so you could just tell us a little bit about what just happened to you.
Hello, everybody. I would highly, highly recommend doing this if you have to, because it's changed my life. I had this surgery May 25th, and here I am now walking. Dr. Harwood said I could drive my car today, which I don't want to do. I can now walk my dog again, which I could not do. This was very insidious. I was not athletic like this lady in her rowboat there, her boat. It just so kind of crept up on me. It started to hurt, and it hurt a little bit more, and before you know it, I was walking the dog in the morning, coming in the house almost in tears. That's how it developed. And finally, my primary doctor said, "You're going to have to do this, and find a doctor who will do it." Now, Dr. Harwood did a hip replacement on me in 2000. I'm still walking around with that hip. And anyway, all of a sudden it dawned on me, and I said, "Oh." So I called up university, and they said, "Dr. Harwood does knees also." So I said, "Wonderful." I called, made the appointment, and that's where it started. Took x-rays, and I was fascinated with this because I really didn't know what had happened to me until I watched this. But, the morning after the surgery, I got out of bed, and it was just a total different feeling. I mean, before I had to sort of be careful, it hurt. Even, early in the morning, it always was good. I got out of bed and I didn't feel a thing. It was marvelous. And so all I can say is thank you. And if anybody wants to ask me anything, that's fine. But don't put it off. Do it if you can. I'm still stiff on the one knee because it's just a month. But yeah, it's great. I just had the Band-Aid taken off. No, just the one, and it was the partial. I don't understand what you're asking me. No. Yeah.
Yeah, so basically we don't lengthen legs with knee replacements, but when you wear your knee out, the cartilage collapses, so you end up getting a little bow-legged. And so what we do is we straighten you out because of the cushion back. So it gets a little longer and you're more even. So if you have both knees that are just as bad, then you might be uneven for a while. We tend usually not to do both at the same time. It's just a lot to go through. You wouldn't have such a wonderful experience as Mrs. Felix did. So I think that's kind of it. So anybody that gets these replacements too, they get a free rowboat shell like you saw in the movie. So yours is coming in the mail. Thank you very much.
Would you elaborate more on the 3D imaging that we just glossed over? When is it done? Is it done in the OR?
So it's not. So there's different types of systems, and some of them use a CAT scan to get the 3D imaging and then map it onto what you see in the OR. This system is completely OR dependent. So I literally take a little pointer and I paint the entire area, all of the areas that were going to be involved in the knee replacement. And the computer knows where my pointer is because of the sophistication in the technology. So it builds, after I do the whole painting thing, it builds a three-dimensional model of the whole knee, the tibia and the femur. And then we can manipulate the implants and the ligaments based on what the information the computer has. And the information is perfect because it's not even an image. It's actually me painting. So it knows exactly where the surface is. So it's done in the OR, and it takes a lot of what? I'm sorry? A lot of the things that are done with this machine.
There's not much pre-preparation ahead of time.
There's other technologies and other techniques, but in this particular technology, it's all done in the OR. So you don't have to get any other tests or studies. You just basically, all your normal pre-op stuff, but not anything related to the planning of the surgery.
You open up the knee, and you had to go pick out something that fit. Is that still?
You still have to measure things, and we still have to put in something that fits. But at least we know what the size and the position of that thing that fits is before we even do the surgery. We're in the surgery, but we haven't actually done the cutting yet. And anyway, I don't know if that answered your question, but
Do you have to keep an inventory of parts? In case
So my operating rooms look more like the Home Depot than they do a regular operating rooms. And this gentleman over here is responsible for all he backs up a 18-wheeler and dumps all these little orange boxes in the OR. And, people in the OR are pulling their hair out, but you're right, we need all these options available to us. But they're in the operating room. We have all the stuff we need. So, question? So we have some similar things with hip surgery, but the hip surgery fundamentally is a different kind of procedure, and it doesn't at this point lend itself too well to this particular device. But there's exciting things in hip surgery as well. So I do minimally invasive hip surgery. You basically are at least as comfortable as the partial knee replacements, and most people go home the next day.
I'd like to know approximately how long is an uncomplicated knee replacement take, and how long are you under anesthesia?
So those are good questions. The knee replacement, if I had 3 cups of coffee, takes about an hour. 2 cups takes about an hour and 15 minutes. And no, it's about between an hour and an hour and a half. Yeah. But that's just my part, okay? So you have to understand that this is a process, and it doesn't really matter because you're in the hospital anyway. But the anesthesia person, takes a while to do the nerve block that we saw, right? So that takes half an hour, and then we bring you to the operating room, do whatever we're going to do for the anesthesia. That takes a while. So the process is a few hours. Now, when you say, how long am I going to be under? So let's ask Ms. FedEx, how long were you under?
I don't remember.
So all I can tell you is it was 0, because all during the case, all during the surgery, while I was operating on her, she kept saying, "Hey, Dr. Harwood, let me see the robot," during the whole surgery. So, and you can't really see because we have everything draped out. So she was on the other side of the drapes. And the robot's on the other side of the drapes too, so you can't really see through the drapes.
I have another question, please. What procedures does the hospital take to keep these kinds of patients who are not really sick away from infections that occur in the hospital?
So we do a couple things. The operating rooms obviously are sterile, and when we do the surgery, so it's about a bunch of different things. Some of it's patients, and some of it's what we do. So infection control is very important. We're very, almost neurotic about it. So when you have your surgery by me, it's done in an operating room, and we literally wear spacesuits. So we're all in these sort of bubble things. It looks like something from the CDC, treating Ebola virus or something. So everything is completely isolated and protected. So that's the whole sterile part. We give antibiotics. We have solutions that we bathe your wound in before we close it to kill anything that might have gotten in there. And then once the wound is closed, we actually have a very expensive, a great bandage that goes on that is an antibacterial bandage, and so it's sealed. So your wound never comes in contact with the atmosphere until it falls off, which in your case was about an hour ago, or 3 hours ago. At any rate, it's very sterile. Most patients get a single room at St. Peter's, so you'd be isolated from that as well. And that's pretty much it. I mean, you can always get a cold or something, but in terms of bacteria, the bacteria is really isolated from any parts that might have been open at the time of your surgery. So, yeah. So are there stitches? So the answer is yes and no. Great answer, right? So there are always stitches that we close the deep parts of the wound with that you don't see. But when we get to the skin level, the stitches are in the edges of the skin, so you don't see them. And then in the very surface, we put this fancy tape across that keeps the wound edges close together and holds the tension off of it a little bit. So it lets the scar heal a little bit better and helps take the pressure off of the wound. So there's no stitches to take off, just that tape at the end.
What is it that gets inserted? Is it to replace the cartilage, or is it to replace the bone, and what is it made of?
So we have examples here, and you can come up and see a little bit later if you wanted to, but it replaces the cartilage, okay? So it's just the cartilage that's missing. So on the femur side, you can see this is a ceramic. It's black because it's ceramic. It's the type of material it is. And on the other side, you see it's plastic, so it's white. And the plastic sits on a little titanium tray. But really, it's very thin, as you can see. Sometimes it looks bigger on an X-ray because you're looking at a shadow. It's going through the shadow. But even the thinness of these devices, though, they still have some thickness. Okay, there's some thickness, usually 8 or 9 millimeters. So we have to shave a little bit of the bone away just to accommodate the thickness of those thin ends. So it's not much, but that's what this device does, is it shaves away just enough bone to accept the implant. And the genius of it is that it's using a burr to do that. It knows what we planned. So if I go near part of this bone or your bone that wasn't part of the plan to be shaved away, it stops. So not only is it ridiculously accurate, it's a safety measure too. So it won't cut any bone away that it's not supposed to cut away. Pretty crazy. What's that? Well, this black material the metal could be substituted, but this is even fancier. So because ceramic is harder than metal. So where you see black here in some patients in some companies, it would be shiny metal. So the femur side's metal, and on the tibia side, it's plastic. Every knee replacement.
This plastic material which we are putting is being used since how many years?
It's been used overall for 50 years in general, but the plastic is what wore out in the old days. Like when I first started, we tell people they'd last 10 years. We were just making it up anyway. We didn't know how long they lasted, but we knew it wasn't infinite. We knew it would wear out at some point. Turns out, and you can imagine that the plastic is what wore out. It's the softest part of that whole construct. Over the years, the biomechanical scientists and engineers have improved the plastic to the point where it looks like it doesn't wear out anymore. So when we put these implants in, they don't wear out. If they're put in perfectly, they don't loosen. So we look like, for the most part, when I put an implant in, unless you have some other kind of crazy complication, which is rare, these implants are put in for life. I mean, I can't guarantee that, but that's what it's looking.
So what is this plastic?
It's polyethylene. It's a high molecular weight cross-linked polyethylene.
Thank you.
So it's like fifth generation of plastic, but it's very fancy. The diamond crystal. So I think what you're referring to is the black stuff is basically ceramicized metal. Now ceramics are sort of brittle; they can crack. But with this specialized procedure that's patented, so they're the only company that has it, they take a metal and they treat the surface so it turns it into something like diamond. It ends up being shiny black like this, but it's the best of both worlds. So it's hard like metal. I mean, it's strong like metal, but it's hard like ceramic, so it won't crack and it doesn't scratch. And so most people get this particular type of device. And it's also hypoallergenic. So for people that have metal allergy, you don't have to worry when you get one of these because nobody's allergic to this particular ceramic material. So the decision is made in my office with me, and we do a couple. Prior to it, once in maybe 1 in 50 cases, I'll call an audible and change it at the time. Then I open the knee up and I say, oh, it's way worse than I thought, but it's not very common. So we look at the knee as 3 parts: the kneecap part, the 2 knuckles, the one on the inside and the one on the outside. So there's like 3 parts to the knee. So kneecap, inside and outside. So when only one of those knuckles is worn out, then the partial is in order. When more than one part, the kneecap or the other knuckle, is worn, then we go to a total knee replacement. It's the same operation, by the way. We still shave the bone, we still put the caps on it, but it's a bigger area. It's a bigger incision, and it's a little more recovery. Still great. Still the same pain management techniques, but it's a little bit longer recovery time. Yeah. A fusion of your spine? Oh, a fusion of the knee? Oh, a tear. Well, the knee has these rubbery cartilages called meniscus. Is that what you're talking about, maybe? Yeah. Oftentimes, people, before they get to this point, there are these little rubbery cushions in the knee that you can twist and catch the wrong way, and they get torn. And the little pieces that are not torn away, but still they get stuck, and in between the 2 bones, and they can hurt. It's kind of like walking around with a stone in your shoe. And so we just basically take the stone out. That's done arthroscopically. So it's way easier surgery than any of what we're talking about here. That is outpatient surgery. It takes 20 minutes, and basically that's a lot easier to go through. That's almost like that's an easy one. Yeah.
Dr. Harwood,
Oh, sorry.
if you not only have osteoarthritis, but osteoporosis, does that cause a problem when you're replacing the foot all the pulsing?
So that's a really good question. So it's not directly related. So osteoporosis and arthritis are different things. Porosis is bone and arthritis is cartilage. But when we do these implants, we need to have bone to support the implant. And so we tend to do them still, but it's good for me to know that the bone is very thin so that when we end up being a lot more gentle with osteoporotic bone. It's always good. By the way, we have a DEXA scanner in our office, and if anybody hasn't had a bone density test, it's a really good idea after you're 65 to get one. Medicare actually requires us to ask, and it's a useful piece of information for me to have. as a quantified thing. It's hard to see on X-ray. Well, your bone density, if it's really, really, really bad or really thin, does it show up on the X-ray? And then it's really bad. So there's in-between stages that you can find on an X-ray scan. And the real good reason to do it is that despite all the horror stories you hear from the news and the lawyers, there's really, really good medicine to either prevent this increase of osteoporosis or to reverse it. And believe me, I've been around for a while. Osteoporosis in its end stage, mostly in women, is terrible. I mean, basically the spine completely collapses. So the reason is there's medicines to stop it. So that's great. So it's good to know whether you have it or not, and if you do have it, there's hope, there's help. Yeah.
What patients are Dr. Butler's? I've seen you in his absence as well. But what I wanted to know is, I have a meniscus that's it was injured many, many years ago. So with the total knee replacement, having no meniscus affect what the total knee replacement that you propose?
It takes its place. So it's not only that part of the knee, but the other cartilage of the knee too. So it changes everything, kind of wipes the slate clean. The only thing that's related is that if you do have a meniscus tear when you're younger, over time it can actually lead to this. So you can't do anything about it, but it's part of the cushion of the knee. So when you take some of the cushion out, or you damage it, or both, it can lead later on to arthritis. But there's nothing you can do about it. So yeah, exactly. And once you get the knee replacement, it's all irrelevant. So Michelle?
Okay, I have a couple of questions. What is the healing time for a partial versus a total? How much longer is a total if you need it?
It's probably about 50 to 100% longer. So if it's a month, it's 6 weeks to 8 weeks. Now, healing time is hard to give you a number.
I know
because it's
individual.
It's individual too, but it's right. It's gradual. So it gets really good in the first month, and then a little bit better. It really gets better and better. You'll find even up to 6 months to a year. So even though it's great at a month, it still gets better and better because your body takes a certain time to heal. Initially, it heals with immature scar tissue in the first month, and then that scar tissue matures over the year, becomes thinner and softer, and so anyway. But it's about twice as long for a total, just in my experience.
Okay, now obviously getting up after surgery, anytime for any surgery, the sooner you can get around, the better you heal, the quicker you heal. What about physical therapy? How soon after a procedure do you start physical therapy, and for about what time period do they run it?
So the therapists are the people that get you up out of bed. So usually the first day, and then you get it every day, usually for a couple of weeks. The goals for knee replacement are not that complicated. Therapy sounds, get therapy, and it's true, but really all the therapist is, the first day or two, their goal as a therapist is to get you to be safe, to do your activities of daily living, go to the bathroom, get out of bed. Once you can do that, you can go home. And then the next goal of therapy, because you have a cut on your knee, right? So it's going to be sore and swollen. Despite all of our techniques, it's still going to be sore and swollen. So the goal for them is to get you to bend the knee, because you don't want to, it's sore and swollen. So you want to make sure you bend the knee and straighten it out, because that scar tissue that's forming will stretch out when you bend it and straighten it. If you wait 2 months before you do all that, then it's like wet cement. The scar tissue is like wet cement. It sets up. And then at 2 months, you can't bend it. So the therapist is really like someone to torture you, to make sure you bend the knee. Sorry, but I pay them to torture you, so it's my...
You kind of answered one question that I was going to ask as far as with the scar tissue. My sister had traditional knee replacement years back. And obviously in the beginning it was fine. And then as the scar tissue started to form more, she had more pain and she had to go back and they had to break up the scar tissue, and she's had to do that several times. With this type of procedure, I'm assuming then there's less of a possibility of scar tissue forming, or is it all related to physical therapy?
It's hard to answer that specific question. It's kind of unusual what your sister went through, so I wouldn't be presumptuous to basically give a solution to it. The general surgery is the same, so doesn't change that. I think the only catch is that if the implants weren't perfectly put in, then sometimes the motion can be stiffer over time. I don't know if that was the case, so don't quote me on that. It's probably physical therapy. So again, it's like wet cement. So the very first month is the critical time. If you get all your motion, or at least beyond 90 degrees in a month, you're home free. You can do whatever. And again, the therapist is really like a coach, right? It's not something, they're there to make sure you do well. But it's up to you to do it. So some people need to be monitored. So I can't come to your house every day for the week. So the therapist is able to do that for me and monitor your progress. Some people, if you could do it on your own, you wouldn't really need therapy because it's not something they're giving to you. It's something you're actually doing. But they're just making sure you're doing it properly and progressing properly. So it's very important, but it's for that reason. And everybody's different. Some people really probably don't even need physical therapy, and other people need a real kick. You know what I mean?
All right, my last question: how long to drive?
It depends. So if it's your left knee, and you're not so there's two limitations to driving. One is your ability to control the car. Okay, so most people drive with their right leg, and they brake with the right leg. So if it's your right knee, then your driving will be at least 4 weeks, maybe 6 weeks. It's not about me, it's about you not getting into an accident. Okay, so it's traffic safety. So the second reason is pain medicine. You're not supposed to drive if you take pain medicine. So if it's your left knee, you can drive right away, but then while you're driving, you shouldn't be taking pain medicine. So most people can drive when their pain level is low enough so that they're okay without the pain medicine, and that's usually 2 to 4 weeks, depending on, at least temporarily, depending on the patient.
When you're in the surgery unit, and you have a backup robotic in case the one working fails, the handheld.
This is it. That's a good question. So, yeah, and you know what? It basically is always a little bit of there's a little level of anxiety for a surgeon who uses technology that they understand how to use it, but if something goes wrong, I'm not a technician that can figure out a computer. So we have technicians in the room, and some of them are actually on the side there, who can fix 99.9% of the problems. In that 0.001%, the backup is what you saw a picture of before. It's what I did for 28 years. And so we have all the traditional instruments that I can still put the knee replacement in as a backup. So that's the answer.
Is there an age limit to have the surgery?
Who asked the question? Oh, okay. Sorry, yeah. So there's no specific age limit, but there are health limits. So as people get older, then sometimes your health isn't quite as good as it was when you were younger. So as those health risks add up, at some point, you and your doctor and I may consider it to be a little too risky. So there's no specific age limit. Basically, I've done 90-plus-year-olds, for sure. But, it's not something that you want to do when you're 90 either necessarily. So you got to weigh all the pros and cons and what it takes to get through a surgery, when you're that elderly.
Doctor, 3 questions. Is the diagnostic X-ray the only imaging that's needed to come up with the determination of either a partial or a full?
Almost always. If it's a partial, sometimes I'll do another special X-ray in the office, but 99% of the time, I don't need anything else, just plain X-ray.
So basically, from one visit, you can basically determine what I would need, or what anyone would need, I should say.
If it's straightforward, like the X-rays that we presented, then yes.
Okay. How long has the NAVIO system been in use, and how long have you been using it?
So we've been using it since November, and it's been in use, 3-4 years maybe, something like that. And so we've been using it since November. What I will tell you, though, is that the setup that you see over on the side, okay, that part of it, the arrays that are attached to the bones, I've been doing that for 20 years. So that's 2/3 of what the NAVIO does. So that's called surgical navigation. So I'm pretty experienced at that. The difference in the advancement is NAVIO completes the circle. So in that system, I would have a plan, but then I would have to use my own hands to guide the tool, like the saw or whatever. And in this case, the robot does all that for me.
Since the NAVIO is a Smith & Nephew product, I assume that it only works with the Smith & Nephew joints.
So I'm not 100% sure. Initially, it was a company that was developed outside in Pittsburgh, because they're basically a center for artificial intelligence and robotics and things like that. It's called Blue Belt, and they had multiple platforms. But since Smith & Nephew paid a lot of money for the company, I think they converged the platform to only Smith & Nephew, but I'm not 100% sure. I use only Smith & Nephew generally, products anyway. So, if you came to me, you'd probably get a Smith & Nephew knee, even if we didn't use it.
And just one last question, since we brought up some questions about driving. A left knee, how would it stand up okay to use on a standard shift car with a clutch?
I mean, it's probably fine. I drive a clutch, so it's rare, but I drive a clutch for the last 40 years. So it depends. It's the same answer though. If you're safe to drive, if you can use the clutch, it's a little less of a threshold because you can still brake with your right foot. So that's the main thing, is to stop the car, right? But it may be uncomfortable to constantly, especially in traffic, right? But it's kind of always going to be your decision. It's a kind of a common sense thing more than an orthopedic answer.
But the implant should be able to handle pressure.
It's never about the implant. That's not ever what the answer is about. Okay, the implant's able to do that in the recovery room. Okay, it's whether your muscles and your reaction time can do it. There's nothing to do with the implant. It's solid. We cement them in. You don't have to wait for anything to heal in terms of the implant.
Thank you.
Thank you. Doctor, you said you did 8,000 of the traditional instrumentations. How many of the partial knee replacements have you done with the NAVIO, and how many total knee replacements have you done with the NAVIO?
I think we're probably up to about 30 or 40. So, and again,
of the partial knee replacements?
Probably a little more partial, probably about 25 partials and 10 totals, because they developed that platform later, so they really started out with the partials.
Thank you.
Yes.
Replacement. What happens if you fall on it?
So the knee is, so remember, it's just a resurfacing, right? So we call it a knee replacement. I didn't really talk about this, but it's a good thing to bring up now. We call it a knee replacement. It really, as you see, it's really not a knee. We didn't replace your knee. Your knee's still there. Okay? It's just the cartilage that's been put back. So if you fall, it's bad, because it's bad anyway, right? It's bad if you don't have a knee replacement. You could break your knee, you could break your leg, you could break whatever. So if you break it right above the implant, it might be a little harder to fix because the implant might get in the way, but it doesn't. You're not more likely to break it, and it doesn't increase your level of risk. Or if anything, sometimes people fall because they have knee pain, so it might actually help in that regard. If you fall for another reason, you can still break your knee, just like you could without the knee replacement. It might be a little more complicated for the surgeon, but something can always be done. It's not a reason not to have it anyway.
Hi. Do you recommend prehab prior to having a procedure done? In other words, strengthening the muscles surrounding the knee?
It depends. I should say yes, but so yes, I guess it's not a bad thing. But I would say doing it on your own is probably a good thing. Save the therapy payments for afterwards. It's always good to be in good shape. To be honest with you, the muscle strength around your knee, unless you're really deep conditioned, isn't going to matter in the long run that much. It's better to rehab get into just general body shape, so you're not out of condition. But there's nothing specific about it, to be honest with you. And if you're going to do anything before the surgery, losing weight is always a good thing. So if you're inclined to be able to do that, it's easier for the surgery to do the surgery because the knee is closer to the surface, so it's quicker and easier. And you're more mobile after the surgery for it. So, and then if you're significantly overweight, you're at a higher risk for infection because it's fat levels. It's hard to explain, but you can't really sew the fat. It's sort of just kind of yellow. So what happens is those tissue planes can ooze. So the wounds are more problematic with larger people. And that's when the wounds break down that you can get, if there's fluid going out of the knee, then bacteria can go in the knee. It's hard to explain, but you're at a higher risk for a little bit higher risk for infection. So if you can lose weight, that's great. If you can't, we'll deal with it somehow. Otherwise, staying in decent health is good before the surgery, but not specific like knee exercises, say, at least in my opinion. You're going to need all that energy for after the surgery. I would save it. Almost never, actually. Sometimes. There is another technology that I use when I'm in other hospitals that we don't have the robot. So it does use an MRI. It's pretty accurate. But either or, I'll use higher technology to make sure that at least that one variable of the patient, of the implant position is taken out of the equation. So I try to do everything I can, throw everything at it like with the kitchen sink to make sure that the patients do as well as possible. Because it is a big step for a patient to make a decision to do that, and they need it done right. And I can't always guarantee the result, but I can guarantee that I always try my best. So, with that, yeah. I'm not sure about the whole state, but I know that there aren't very many NAVIO machines around here. I know there's, right, we have one in our surgery center, which occasionally people are candidates for outpatient bone replacement. And that's all I know. So our office, this hospital, not Robert Wood and not Somerset. And as far as I'm not an expert in all the other hospitals, so I don't actually know. Yeah.
St. Peter have its own facility for rehab. Does St. Peter's have its own facility for rehab?
So rehab means different things to different people. So do you mean physical therapy? Okay, so they have a physical therapy unit here, but as far as I know, they might have, I don't actually know, to be honest. Do you know, Michelle?
My staff are the people who are going to see you right after the surgery. Those are the therapists who work in-house. And there are two facilities where you can get outpatient therapy, one of them here within the hospital, and the other one up in Somerset at the Piers 2, which is just on the other side of Franklin Boulevard. They do outpatient therapy there. If you're talking about so sometimes when people talk about rehab and if you've had a knee replacement done a long time ago, people went to rehabs. We don't have that, but people don't do that anymore. You go home.
Okay, and we do have, for the occasional patient, we do have the ability to send them to a rehab center. But basically, they're nursing homes and they have bacteria, and it's basically not a great idea. The only people we have go there are people who are really alone and they have no help at all. And it's few and far between, but occasionally. So, any other questions? Okay.
When can you get it wet? When can you get the surgery site wet?
When the wound is healed. So when can you get it wet? When the wound is healed. And generally, I put this fancy, we talked about this fancy dressing, this kind of it's like a big Band-Aid, and that is got silver in it, which basically is an antibacterial, so it's expensive. So I'd like to have that stay on for a week at least. There's another bandage underneath it. That I leave on until it falls out or until you come to see me in the office and it's still on. And some people have both on it. But about a week is when I want the nice bandage to stay on. By then the wound is pretty healed. You could get it wet, but I would prefer that you leave the bandage on, so it's better for a week. All right, guys. Well, I thank you all for coming out. I hope this was a useful way to spend your, evening. There's Jersey Mike's over there if you haven't had